I saw in the paper in the Sun-Times today that 9 people were killed in Chicago over the weekend, which is the most in 18 years, and 15 were shot, including a 7-year-old girl. So this is something that people face in the city every day, or don't face. People such as ourselves sometimes turn away from it. But my first question is, that's not something that Sinai can do. I spent time in their level 1 trauma center in October doing the story, and I saw that the people just coming in 24 hours a day, 7 days a week. And so what I'm asking is that how does Sinai try to prevent violence? I mean, obviously someone shot, they come in, you have to take care of them, but you also work with the community trying to keep them from ever being shot. And that's something people don't think about, and I thought we would start there.
Yeah, and you know, that is, first of all, thank you, Neil. And I do have to say, if you've read Neil's promo in the Sun-Times, never have I ever seen the phrases emergency department staff and singing sea shanties used together. So I think Neil gets some applause for that. So, you know, I mean, that whole issue of, yes, we treat people, obviously, when they come in and we get them well and we send them back out. But I think there's the bigger issue, if we dig into what is the bigger overriding issue about this. When you look at the trends in Chicago in homicides, there has been, between 2017 and 2018, a 14% decrease. And that sounds really good, right? But then when you dig in and you look at the more of the social issues and the disproportionate burden of who's impacted by those homicides, 80% of the homicide victims in Chicago are African American and 16% are Latinx. So there's kind of, for me, a bigger issue of, you know, how do you start addressing these kinds of problems? And of course, so much of what we see is post-traumatic stress disorder from this, and it's so much a bigger issue than just people coming in and getting treated and going. I'll tell you what Sinai, just to give you a few examples of what Sinai does, maybe 5 quick things. One is that we have community health workers who are people from the community trained in issues like chronic disease and trauma, who are in our emergency department, our trauma center. We're a level 1 trauma center, obviously, at Mount Sinai. And as soon as the patient is stabilized, we're working with them through our community health workers to make sure that they're going back to a safe environment. Do you have a safe place to live? Do you have food? And we'll talk more about that. We also we partner with an organization called Aclivis, and they do something a little bit different, but also, I heard the applause there, also in our emergency department. They are the violence interrupters that we've heard so much about, and they want to make sure that there's not retaliation. Third thing is behavioral health. I mentioned post-traumatic stress disorder. From our research on Sinai Urban Health Institute, 1 out of every 4 people, 1 out of every 4 people in the communities that we surveyed, 9 vulnerable communities, have some sort of post-traumatic stress disorder. And when you're a witness or a victim of trauma, you can imagine how that's multiplied. So we have a full range of behavioral health services. I'm like a bad date. I warned him about this already. I'm just like...
It's very hard for me to be quiet and listen to someone.
He's giving me the signal.
No. I was sort of doing what I was thinking about as you were talking about treating the community is one of the things that I was most struck by when I was there for a few days in October, and of course didn't get into the story, was that a number of people who came into the ER were not in fact sick in a critical sort of way, but they were alcoholics and drug addicts and homeless people and people with mental health issues. And at the hospital, you remember they were there for the sandwich, and people they were treated very kindly. And some people were sort of like put in a little bed in the corner. They didn't need treatment, but they needed to be there, and people would chat with them. And I watched very carefully how they were dealt with. And they were dealt with a lot of respect.
Thank you for noting that.
And it was...
I really appreciate you noting that, because I think when you work at, whether it's Sinai or any of our colleague safety net hospitals, you know, across Chicago or across the nation, I mean, people choose to come to work at a safety net, not because it's the most beautiful place to be. I mean, I'm always amazed when I go to other hospitals and they have matching furniture. But, you know, I mean, it's
Those self-playing pianos like Evanston.
right, in the waterfall. People, it's almost like a self-selecting group that you come because you have a certain mission in your bones that you want to make a hands-on difference. So I'm glad to hear you hadn't said that to me before. I'm glad to hear
You
that
mentioned
saw
safety
that.
net, and I mean, I know most are healthcare professionals, but this is the city club, and so I assume some people are networking for jobs or dates or whatever. So let's talk about what a safety net is. I mean, people use the terms emergency room, trauma unit, et cetera.
Sure. Yeah.
What is a level 1 trauma center, and how is that different from just an ER that you go to?
Just a big ER.
Right, just a big ER with a deep staff.
Yeah, so Level 1 Trauma Center has the highest level of equipment, highest trained level of personnel, and the array of medical specialties that you would need to address some kind of trauma, whether it's a homicide, whether it's vehicle trauma, and differing levels of level 1, level 2. I mean, the interesting thing is that I know one of the things that we talked about was funding for level 1 trauma centers, and that it's not a profitable thing. There's actually been an increase across the country. There were almost 120 new level 1, level 2 trauma centers opened across the country, despite it not being profitable.
So I was going to ask about that. You need support from often the federal government, not to get into the whole federal government issue, but our president's budget fell yesterday, and it's bad news for social services.
Yeah.
But I get the sense that so far, whatever crisis is coming from a funding point of view hasn't come yet, that the money is still flowing from Washington to keep the doors open. And the lights
I mean, we'll keep the doors open. It's, trauma, like behavioral health, is a public health issue at its very core. We have to have trauma centers, and we have to have them in the areas that are most plagued by the trauma. So yeah, we have to keep the doors open. But an interesting phenomenon, because when I looked at the growth in trauma centers, and it kind of has you scratching your head, like, why would people? Because what you asked me about is true. It's not profitable per se. But with the Affordable Care Act, with more people who had been uninsured now being able to access insurance, all of a sudden in the areas that we serve, and we refer to them as vulnerable communities, people who had not had insurance before now do. So some of that's going to be covered. There's also this halo effect of being designated a trauma center because of the very excellence of the caregivers. Whether you are a safety, and we're one of 5 trauma centers within Chicago city limits. So whether you're a safety net trauma center like Mount Sinai, or like our colleague Stroger, or you're at Northwestern, I mean, this is still, we still need to have the trauma centers open. So more people insured, but there's also the effect of the perception. If you are a level 1 trauma center, you have that high level of skill, so you must be good in other areas as well.
You need people on call. You need, because you never know when you're going to get shot. You need an ophthalmologic surgeon or that kind of thing. And whenever people ask me about, what would you do, Neil, about violence to curtail it, I always say, well, I would do everything, because it's jobs and housing and family and addiction and prenatal care and everything. That violence is a cause and a symptom. It causes these things, and it's the result of these things. So after you treat a patient, how do you follow up as far as food and housing and education? I mean, I assume you see a lot of situations where you slap a bandage on it, and what else can you do? How does Sinai we talked about the community a little bit, but also how does Sinai try to kind of keep the person from getting stabbed again?
Well,
is that valid?
That is a big question. When we look at where resources are invested in Chicago, and I'm, as Dr. Mazur pointed out, I'm a native New Yorker, but have been here a very long time. I've really come to consider Chicago my hometown and love Chicago deeply. And People have heard me speak, my thing is we can't have two levels of health care. I live in River North. We can't have one level of health care in 60611 and an entirely different one if you happen to live in 60608. So I think the whole issue of, number one, we have a deep Chicago Community Trust called our Sinai Urban Health Institute door-to-door survey a treasure trove of data, and we should use that data, looking at where is the food insecurity, the unemployment. In some of our communities, we have 7 times the unemployment as the rest of Chicago. So you think about what causes the violence. This goes back to the very first question. It's all related, and these have been big ahas for me since I've been at Sinai. But people need jobs. They need to know they have a safe and reliable place to live. All of these things contribute. They need to have choices people are making. They need to have food. All of these things that make a stable, productive, and vibrant community are things that we as Chicago, and certainly the civic community, need to be investing in, because we're never going to be a healthy city if we're healthy on one side of the city, but a scant 6 miles west and then south, we're facing all of these really life survival issues, as you point out, Neil.
Well, as a newspaper columnist, I make the assumption, and it might be a mistake, that if I don't know something, nobody knows something. So with Sinai, when I think of it, I think of it as only the trauma. I mean, I don't think of things beyond it. One nice thing when the Sinai people approached me is they didn't say, hey, let's talk about our new CAT scan or whatever, but I was sort of interested to get beyond that and also not have that be the tail that wags the dog, but sort of say, what else are you doing that people never hear about because they only hear about the ER?
Yeah, that's a great question. There is sort of two sides for that as we were thinking about this. One side is kind of the negative, and I don't want to gloss over it before I get to the positive, because I think it's so important. It should be important to all of us in the room. It's the impact that doing this kind of critical work has on the very people who are doing the work. I read an interesting study the other day. It was put out by it was called the International City County Management Association. Who knew there was such a thing? But they put out a really super interesting article about emergency medical, the first responders, and it had to do with suicide. And from this huge survey, it turns out that, and I think this is applicable to hospital workers as well, and certainly in the safety net, it turns out that the first responders had contemplated suicide at a rate 10 times that of the rest of the adult population, and actually attempted suicide almost 7 times that rate. And you got to think, I mean, it has to have something to do with the kind of work we're doing. So we're always cognizant of, the issue of caring for the caregivers, and that's one thing that I think isn't as evident. We always think, you work in the emergency department, oh, that's nice, you go to and you clock out, and that's not the way it is. It stays with us. Okay, so
that came out in the story a bit, and I didn't go in and tell you that, but that's what I saw. It was that you care for someone, and then you have to care for yourself, or you can't show up the next day to care for them again.
Oh my gosh, so true.
And some of the stories people were telling me where the victims are coming in from a fire, and this victim was clinging to one of the nurses, and she kept trying to kind of get her to the place, and only later did she realize that this was her cousin, and this was her family coming in, but that they were so smoke, sooty, et cetera, from the fire that she didn't realize it, and how, she said, I had to call my pastor that day. And part of the story, and do go online, it was called Code Yellow, and you can read it online, and my name in Mount Sinai, it'll pop up, was about the nurses looking out for each other, seeing when people were withdrawn, and I'm talking instead of asking questions.
No. It was very, very important. We felt that you really nailed that, and what you said in your promo wasn't going to be necessarily a pretty piece, but you got it. I think the highest compliment is that the caregivers said, "That's it." I mean, that's what it's like, and that's it's negative, but it's also a it's just incumbent on leadership to be able to look out for the caregivers and be able to recognize when people are just not going to be able to continue to carry that burden, and then getting in there and really helping to address that. And as you said, the caregivers looking out for each other. I think the other thing that, we talk about what might people not realize about Sinai, or where we're sitting right now, is that Sinai, we're 100 years old. We just passed our 100th anniversary, and and serving the same vulnerable population. Started out with the Jewish Eastern Europeans, and the community has changed, but the mission hasn't. But what we've done for decades is a lot of teaching and really preparing the next group of healthcare workers. We have at any one time over 700 students, whether it's residents, people in fellowship, pastors, pharmacists, nurses. So Sinai is really teaching and preparing people for that next, their next roles, and it's so badly needed in healthcare. We have a research institute. I've mentioned that several times. We've got Sharon Homan, president of Sinai Urban Health Institute, that's got epidemiologists and biostatisticians and community health workers really digging into, because we've got to do this to be able to solve the problems like the violence in Chicago. We have to understand what's causing it, or else we're just throwing money at a problem that we can't dig into. And I see we've got a DePaul table here. We love our DePaul colleagues. We work so closely with DePaul on urban health solutions, and so we're happy to see you here. But we've got to dig in and understand it. We've got a community institute, Sinai Community Institute, that's got just 14, 15 very relevant programs in the community, and people may not be aware of that. Our partnerships, we can't do anything alone. We partner with not only Chicago Department of Public Health, but also organizations that are looking at, we've got people returning from jail. What do we need to do to get them to work? We've got to invest in the workforce development. We've got many partners around that.
Speaking of partnership, as CEO, you go around the country, you see other places, other cities, how they're addressing the issues that Sinai is addressing. How do we rank compared to other cities, and anything that you've noticed that other places do that we could consider doing here in Chicago that might help solve the things we're coping with?
Boy, if ever there was a trick question, it was that one. Well,
I'm sorry.
I think there's only one answer. We're the best, right? He said, how do we rank? Well, of course we're the best. Yeah, okay.
But you don't have to be the best. The president has shown us that claiming to the best doesn't necessarily make you the best. I'm not in the same boat, but I'm saying you don't have to say that. Yeah.
Okay, no argument there. Well, I think we're not.
Move on to the next question.
No, because it is a really great question. There is this wonderful fellowship. I mean, that's the interesting thing about healthcare. It is, and we were just talking about this. I'm trying to think, who was I talking to? We've got so many friends of healthcare here today. When I sit on the board of America's Essential Hospitals, which is the Safety Net National Association. So I get a chance to talk to people about what they're doing, and there's a prize called the Gage Awards, and I'm on the award committee. So I had the privilege of reading over 40 different projects from across the country to see what people are doing to address these very issues that we're facing here. And I think the good news is that healthcare has a lot of fellowship and partnership and collaboration, and we share together. But we're facing food insecurity. Henry Ford in Detroit has a wonderful program in large safety net, partnering with Food Depository to actually have a grocery store where people are writing prescriptions for that. We're doing something similar here with a number of hospitals through Westside United and within Sinai's own ED. But there are issues of the food insecurity, housing, county-wide vaccinations that virtually is being done across the country. So I think there's a lot of sharing both ways.
Just can I tell a quick story? Because
Yeah,
just going to a different place. I do medical stories sometimes, and last year, or 2 years ago now, I went to Philadelphia to CHOPS Children's Hospital of Philadelphia to talk to a plastic surgeon who was bringing muscles from a kid's thigh to his face so that he could smile. He had been cancer had taken his ability to smile away, and so they're giving me the tour of the hospital just because I'm there. And there's this big room. It says Mother's Milk Bank. And I said, well, what is that? And they say, well, you know, a lot of the premature babies and blah, 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 and they're given milk, and so this milk is collected. And I said, well, but who gives it? And they said, well, it's often women whose children have died, and they donate this milk as a way to help some good to come of it. And I did a story last year in the paper, and I never would have guessed that this was a thing had the woman not been strolling me through the place. So just getting out and seeing other places is a great experience.
Yeah, that is a really interesting story. And if you don't mind, I'd like to just go back to something, because you said what wouldn't people know? And somebody reminded me of a story. We have Chicago's largest refugee clinic. Of course, before 2016, it was very, very, very busy. And I don't say that in a joking way. And the number of refugees coming into Chicago has gone down, but there's still a need for medical clearance. You have to get cleared when you come into to Chicago. And somebody reminded me of the story that our clinic, which has been around for a very long time, had a family that landed at O'Hare. They came from the Congo. And one of the children, an 8-year-old, became very, very ill on the flight over and landed at O'Hare and died. The family still needed to be, the family was quarantined, still needed to go through their medical checks before they got onto their final destination, which was Texas. So our clinic, which was at the time on Touhy Avenue, gave them, their medical care, and could have said, checkbox, bon voyage. But once our staff learned what happened, one staff member, and mind you, nobody asked them to do this, one staff member started a monetary fund drive, so that they would at least be able to bury the child. One staff member did a food drive, and just and a clothing drive, and just on and on. I mean, just imagine you land in a foreign country, you don't speak the language, you don't have relatives there to greet you, and one of your children passes away. I mean, so these are the kinds of things, similar, that generosity of spirit that we see in health and social services for vulnerable
Telling that story about the immigrants, Sinai has this 100-year tradition, and we take for granted that it's here, but I was thinking of Michael Reese, the former hospital, which used to have in its charter that they had to treat Russian immigrants when they arrived. And what they found was a lot of the immigrants had ailments that we don't have. They would complain of tsirtsi bolit, which was heartache, and they would want valerian root and different things that they really shouldn't have. And it was amazing just to see the number of Russians that depended on them for survival. You mentioned mental health, and let's talk about that, because that's something that you deal with at the hospital, but that we as a society still, there's a stigma. I know we have the Kennedy Foundation here trying to deal with people and trying to. Do you find that even in your community, when patients come in, that there's a reluctance that people have to seeking that kind of treatment as opposed to medical treatment?
Yeah, and in fact, that's where I first heard Neil. He spoke at the Kennedy Forum. I immediately went out and bought 2 of the books.
Out of the wreck I rise. I should have brought a copy.
Yeah, it was really wonderful. But I think that Kennedy Forum is a fantastic. Started by Patrick Kennedy. For I think 2 major areas of focus. One is to lessen. Obviously, we'd like to eliminate the stigma attached to mental health and substance abuse. And the second is parity in benefits, that these are illnesses. Those are 2 things that I'm very proud that Chicago has Kennedy Forum of Illinois, and of course we're part of that. We ourselves believe that there's got to be, and again, behavioral health, not unlike trauma, is one of those services that is so needed, and that was like a big, you take out your yellow highlighter and highlight that in the Sinai Urban Health Institute research on what's needed in Chicago. And so we're really focused on how do we reinvest in healthcare. When we got monies in from the Affordable Care Act coming in, people used to treat who had no money, now had insurance. We reinvested that. We invested $10 million on our South Campus at Holy Cross Hospital in much needed mental health services, opening up a brand new unit. There was no inpatient for services for, God bless you, between 3 and 5 miles around Holy Cross. We opened with the Catholic Charities an outpatient services. There were no services. So reinvesting in the access to services is just wildly important. And then we also have to be role models in terms of acceptance. And within our system, we have a number of programs between what we do for our caregivers, our own caregivers, and then a special focus on physician wellness as well.
You mentioned suicide. Is addiction a problem among staffers and that kind of thing, the way it is with police officers? And
I'm sorry, is suicide
you mentioned
addiction?
suicide
Yeah.
as a risk of healthcare workers, and I was just wondering if maybe this is talking out of school, but I was just...
No, I'm just thinking, because I will honestly tell you, do I think it's there? Yeah, I'm sure that it's there. Has it risen to, I can only speak for Sinai, it has not risen as an issue at Sinai, but we also make sure that our leaders are focusing, as I mentioned before, focusing on keeping that eye out for who really seems to be struggling. A little pivot on that is we have, what has risen up is, and I've never seen this at any of the hospitals I've ever been at, we have, I think, a disproportionate share of caregivers who have, through violence, mostly random homicides, lost, and it's typically a husband, a son, typically male. We have caregivers who have said, coming to work was the only thing that got me through this. And this is terrible to say. I'm proud of it, and it's a terrible thing to say, to have to say. We have a group of caregivers that form, picture like a telephone tree. Because inevitably it happens, when one of our other caregivers loses a relative, the word spreads among this group who have been there, and they reach out to the caregiver. They know about it before any of us do. They reach out to the caregiver and make sure that we know what the caregiver needs. And sometimes it's something that I hope that none of us would even be thinking about. Do you have enough money for the funeral? I mean, we've had caregivers who've had to do that. So those are the kinds of things. It's more, back to where we started, it's more the violence.
Well, that was one of the extraordinary things about the story was the head of your trauma center I asked her how she got interested in doing this work, and she said, well, she was mugged and stabbed, and then seeing the treatment she got made her want to transfer to that part of the hospital, which is a real personal commitment. We're running short on time, and we're going to get to the questions, but I wanted, in parting, we've kind of looked back over 100 years as well, but I wanted to, since you're here and you've got plans, and maybe there are some plans that you could share with people so they can say, I was at the City Club and we heard Mount Sinai is doubling in size, building a new tower, whatever that is that you're doing that you want to share with us.
Thank you. Even though you did say in your promo we couldn't talk about our 100 years of, what was it, uninterrupted change.
Success. Yes. So, well, that's...
But a few things that we're really excited about, because with all the things that are still challenges, and it's not just challenges for Sinai, if we're in Chicago, it's challenges for all of us, but the things that we can look forward to is the reinvestment into these traditionally disinvested communities. We have a program that I think really embodies the new spirit of investment in communities like North Lawndale. It's called Ogden Commons. You might have read something about it, but it's a partnership with Cinespace and Habitat, Chicago Housing Authority, and Sinai. And it's going to bring on Ogden Avenue 11 acres of mixed income housing, about 450 new units right there. It's going to bring retail. we have no retail. It's going to bring 3 restaurants. I know that sounds like a small thing, but if you walk out on Ogden Avenue, there's no place right now. Dr. McKinney, who's here with us today, has done an amazing visionary in the Illinois Medical District, is really changing the face of what's going on there. And just west of Western, we are emulating what you've done so well for the city. So we have Wintrust Bank is taking space there. There's no bank. These are the things that make a community healthy and productive. So we're super excited about that, and we're moving some of the programs that are much needed, like dialysis. We're going to be able to double space, ambulatory surgery. So that's coming up. Expansion of our emergency department bays so that we can have more, again, sadly, there's a need for this, but we can have more ambulances come in and get treated efficiently. And then big shift from inpatient to outpatient. That's where healthcare is going. We want to shrink the hospitals and really be out in the community, partnering with our community partners, with healthcare clinics and our schools. But it's not about the hospitals anymore. It's really about keeping people healthy where they live. So I see we've got some questions.
We do have some questions. I don't say where these are from, correct? Or do I say where these are from?
Yeah, sure, give them credit.
Okay.
It's not like the whistleblower
This is
thing.
from, I don't want to embarrass anyone is the thing.
We don't let anybody skate by with anonymous.
Okay, this is Dr. Bruce Handler. And he says, as a physician,
Oh, I'm sorry?
As a physician, do you predict successful
He's
pushback?
asking me as a physician.
Yeah, or maybe he said, as a physician, do you predict successful pushback of physicians against insurance control, check the box EMR, or worsening business as usual, including burnout, depression, and suicide?
Yay. Okay, well, I don't know where Dr. Handler is. I am not a physician. Again, I can only speak for Sinai, and I will tell you that one thing, I've been in hospitals all across the city and in the suburbs, and one thing that really struck me about Sinai when I came there 13 years ago was it's not a physician mentality of us against them. It's really a circling the wagon about how can we, as a care team, keep people healthy. So there isn't that divide that I think maybe some communities are seeing. Look, do physicians, and I'm sure other caregivers, hate when there's an electronic medical record that's being put in? Yes, everybody bemoans that, and everybody says, well, it takes me away from the patient. And I think that if you don't watch for that and prepare for that, that's true. But in the big picture, it's not an us against them. It's really how do we work together to do what we need to do.
This is a bit out of your bailiwick. It's from Ted Z. Manuel. He says, what are the prospects for medical care in sparsely populated, thinning out parts of the country, which I guess Illinois, if we're not careful, where doctors and infrastructure are scarce? Do you have any insights from Sinai that could apply to that?
Well, not so much from Sinai per se, but I did serve on an American Hospital Association task force on critical access and safety net hospitals. And ironically, the conclusion we came to, not much of a surprise, that many of the same issues that we face, even though we're in an urban community, if you were a physician in private practice, you wouldn't set up where we are because you quite simply couldn't make a living. It's the same thing with the critical access hospitals. But this is where we learn to work creatively. Community health workers, and not taking the place of physicians, but community health workers helping to keep people healthy and identify people who are at risk and getting them into care. What we call mid-level providers, which would be nurse practitioners, for example. Being able to go out to homes and provide care and then get people into care. There are ways besides having a physician on every corner. We're blessed in Chicago with so many medical professionals and schools, but there are ways to get health care to people. Telehealth is another big issue, of course, which is kind of a godsend.
Is that a real thing? Because I see those ads and I'm not,
It is a real thing, and in fact, on your smartphones, right? That is a huge application that people can access, and it's not just for the critical access, the rural hospitals, or for the safety nets. It's also a level of convenience, that you can pull out your phone, and literally, and I've seen this application where you can show a rash to to a physician if you've got a high-resolution phone, and the physician is going to either say, yeah, you need to come in, or, go to Walgreens, I'm going to, at our Walgreens table. Yay! That was unintentional, guys.
Yeah.
But you can, I hope CVS isn't here, sorry. But you can now, you can get your health care without having to show up in the emergency department. So lots of creative ways. That's the exciting thing about healthcare. We've got a world of technology intersecting with the human touch where we're going to be doing things differently.
Okay. This is from Gayla Brockman from the Michael Reese Health Trust. So I'm
Yay.
glad we had a shout out to Michael Reese. She says, talk about how the merger of the 4 hospitals, Mercy, South Shore, St. Bernard, and Advocate Trinity impacts Sinai.
Okay, so, and we applaud, we just sent out an email to our staff, and the aggregation of safety net hospitals is something that Sinai has been talking about for the last 2 to 3 years. So we are applauding that on the south side. And particularly those hospitals, 3 of the 4 are east of the Dan Ryan. We're applauding. We all have to do things differently. We are in the era of healthcare transformation, and that means that for the overbedding that we have, and it's true across the country, but it's true in Chicago, we're all going to have to partner together to do things differently. So we are applauding. We're talking with them about Holy Cross is on the south side, and whether it's a merger, whether it's a collaboration, there are a lot of ways to get at that same end. So we don't know what their group is going to end up actually looking like, but according to the state, this is just the start of what the state is going to help support. So thank you, Galen. It's a really great question.
Marie Bullock, I assume this is sort of a theoretical question you're asking and not something that's she says, if Sinai received an unrestricted philanthropic gift of $20 million, what would you spend it on?
Wow.
Better CEO suite, or?
I can tell you that'd be the last, that'd be the last thing. Oh my goodness, Marie, thank you. What would we spend it on? I would assume that we would be looking first at how do we, and when I say Sinai, if we got a gift like that, yes, there are a million things I'd like to do. We're in some of our facilities, not necessarily the patient care ones, but we're a big campus. Some of our buildings de facto are 100 years old. We would love to downsize the hospitals. We would love to and have something new for our community. But I think just thinking about the way that healthcare should go and how it's transforming, we would look for partnerships that would impact the totality of the health in the communities that we serve. So that means things like the food insecurity and the workforce creation, because that all has to do with great health. Marie, do you have a lead on that? Is that, I'm just, it could be.
This is an interesting question from Megan Everett at the McCormick Foundation. She says there are about 400,000 veterans in the Chicago area. She says Chicagoland because it's a Tribune thing, but I'll say the Chicago area. Representing all races, ethnicities, and neighborhoods. Not all veterans can or want to use the VA. They often face with health disparities, both mental and physical, etc. How does Sinai address military veterans?
Yeah, good question. I do want to give a shout out again, similar to Michael Reese Health Trust, to the McCormick Foundation, who have been not only great supporters of Sinai in a number of our important projects, but also of Chicago and the needs of Chicago. When the VA here received a new director, maybe 3 or 4 years, maybe it was 4 years ago. And we had a wonderful passion for vets and making change. And we had the opportunity to go out and sit with his staff and sit with him. And what we've agreed to is what they cannot handle, and to the extent that we would, and of course we would accept whomever wanted to come to us. But we want to be respectful of where insurance coverage is, but very open to collaborating and serving.
This is from Olison Lawrence asks, tell us more the relevance of this talk to individuals in group homes.
I'm not sure what group homes means. Is Olison here? Maybe we can clarify that?
Yeah, like as opposed to individual treatments like misericordia type of thing, because that's a controversy.
Adult developmental group homes?
Yeah.
Integrated living arrangements?
That's all I could think of. Maybe that's sort of not quite.
In the community where adults with developmental disabilities live.
Yeah.
Okay. You know, we have, thank you. We've got, did everybody hear that? It's adult group homes where adults with developmental disabilities might reside. You know, we have so many partners out in the community, whether it's Catholic Charities, social services, and we don't believe that we have to do, and we can't do everything, nor should we be. So wherever if there would be a need for health care, if there's a need for education that we provide, we're always ready to partner. We do not, and there could be something going on that I don't know about. It wouldn't be the first time, but we do not have a direct care provision to a home. I'm going to look at my tables. Do we have a developmental disabilities? I don't think that we have a tie. Is that correct? So we're not providing direct service, but we would always be happy to partner to be complementary to services that are needed.
Can I put in 2 cents on that? Because to me, there's such a ghastly history of large-scale homes for people with disabilities in Illinois that it's given them a bad name. And perhaps I'm too influenced from writing about misericordia occasionally, but to me, it should be a continuum of care where some people are on their own and some people need to be in group settings. And that I don't see reason why, you know, if you're in a patient-oriented or a person or humanity-oriented system, I don't see why you have to choose one or the other when people have different needs. But that could be Sister Rosemary Connolly speaking through me like a ventriloquist. So I don't know. One more question. Ted Manuel again. He says society already pays the cost of medical care for the indigent through padded prices for their own insurance and through calculated overcharging by hospitals. It's socialized. I don't know if this is a question. How can society accept that reality and change our overall approach? I don't know if I want to accept that.
30 seconds or less.
Yeah.
I don't even know where to start with that one. I can tell you that I can only speak from the safety net perspective, and we certainly are not benefiting if there are padded charges. We certainly are not benefiting when you've got 60% Medicaid, 20% Medicare, 7% absolutely no pay. The safety net community is not thriving based on that. I think that the best that we can do is to look at who really needs the care and what resources do we as a society, and certainly as Chicago, need to get behind so we can really make this a healthier Chicago for everybody.
And then we have a big...
Thanks for watching, and if you haven't already, please consider subscribing to our channel. And while you're at it, please leave us a comment. Thank you for watching.